and Newborn Health and Reproductive Health in WHO Regional Office for Africa. We want to welcome you all who have faithfully attended these sessions, and we hope that you attend today's, you enjoy today's session. The session today is really the culmination of the series that we have been having with the first 2 webinars that gave us an overview of all the different sections of the labor care guide. And for today, we are going to share experiences in introducing the labor care guide into maternity units. We have with us a very wonderful panel that will discuss this. The panel for this particular webinar, since we were targeting nurses and midwives, we have a panel of nurses and midwives that have been directly involved in the testing of this tool and implementing it in the pilot sites. And they are going to share with us their experiences in using or introducing this labor care guide. We will do this through a roundtable discussion that will be facilitated by Abdullah, moderated by Abdullah from UNFPA, East Southern Africa region, and Fatima Gohar from UNICEF, East Southern Africa Regional Office. After that, we shall have a time when we can be able to address any questions that you may still have about this very important tool. We will also be able to give you some information on how you can access technical assistance to introduce this tool in your country. And we have some closing remarks from the 3 agencies. This is a webinar series that has been organized through the collaborative effort of WHO, UNFPA, and UNICEF. We have the privilege of having the scientist from WHO HQ, Dr. Mercedes Bonnet-Semens, who has been at the forefront of the development of this tool and the intrapartum care recommendation for a positive pregnancy, a positive childbirth experience. We have the panelists, as you can see in your screen. They include Veronica Maria Pingray. She's a midwife and epidemiologist at the Institute for Clinical Effectiveness and Health Policy in Buenos Aires, Argentina. And she was part of the team that coordinated the research studies and project evaluations to develop the labor care guide and its users manual. She has also been one of the main presenters in the last 2 webinars that we have had. We also have Rose Laisser, who is a senior lecturer in midwifery at Gohar, Mwanza, Tanzania, currently engaged in NHIR stillbirth studies and was involved to lead the Tanzania sites in the labor care guide evaluation. Rose was also one of the key presenters in the last 2 webinars where we were introducing the tool. With us today, we also have Prisca Ringia. She's a registered nurse midwife and nurse manager at Bugando Medical Center, Mwanza. She has 20 years experience at the Department of Gynecology and Neonatal Units, and she's engaged in helping baby breathe projects, premature abandon, and use the LCG to women during the evaluation. Angela Rehumbiza is also on the panel, nurse midwife at Bugando Medical Center, Mwanza, with 15 years experience in labor ward. She used the labor care guide during the evaluation in 2020, and she has participated in several other projects to include validation of data in a stillbirth study in Tanzania. We have Caroline Holmer, who is a professor of midwifery from the Barney Institute in Australia. She was part of the guideline group that developed the labor care guide, and the study that originally tested the labor care guide in practice, led by Joshua Bokia. We also have Professor Tina Lavender, who is a professor of midwifery and the head of the LSTM's new Center for Childbirth, Women's and Newborn Health, and who has also had the experience in the introduction of the labor care guide. And finally, we have Violet Khonje, who is a registered nurse midwife, currently working as labor ward manager at Queen Elizabeth Central Hospital in Malawi, and involved in the online survey for LCG, and also supervised midwives who piloted the LCG. As we have indicated, we will have some introduction that recaps what we have had in the last two webinars by Dr. Mercedes, and we have our two very able moderators, Muna and Fatima. Muna is the health system specialist that is really leading the maternal newborn health work, among other things, at UNFPA, and Fatima is the maternal newborn health specialist at the UNICEF ESAR. And so with this, I want to welcome you all. The real requirement that we would like from all of you is active participation. Feel free to ask your questions. Feel free to put comments. We will request that you put comments and discussions in the chat, and you will be able to put the technical questions in the Q&A section so that we can be able to pick them up quickly and address them as quickly as possible as part of the session. So without further ado, I would like to hand over to Mercedes and the team to begin the technical presentation to the session. Over to you.
Thanks, Nancy. And I'm really pleased to be with you again. We thought that we should start this webinar with a brief recap on what we have been covering in the last two webinars. Although I think that most of you attended both of them, maybe some of you are new, so it will also help you to see what the labor care guide is and understand why we developed this new tool. So I will start sharing my screen. Okay. So as I go through the slides, you will recognize some of them from the previous webinars, but we really hope that by now you know that once after the publication of the WHO recommendations on intrapartum care for a positive childbirth experience in 2018, we initiated this work of developing a new tool to support labor and childbirth monitoring and implementation of these recommendations. And this was basically because of two main things. The first one is all the new evidence and new understanding on how labor progress varies among women. And the second reason is all this big shift that has happened in the last years around ensuring that women also have a positive experience during childbirth. And therefore, we needed to adapt the previous partograph to incorporate all this new understanding and this shift in thinking to ensure not only good clinical care, but also a positive childbirth experience. So I think that you by now are familiar with how the labor care guide looks like. but is the tool that you can see on the right of my slide. So what are the aims of the SDG? It was designed for you to be able to monitor and document well-being of women and babies throughout labor, also to promote provision of supportive care, and this includes companionship, pain relief, being able to eat or to drink during labor, and also to ensure that women are mobile and they can, and therefore you can, record also the posture that she's having throughout active first stage and second stage of labor. Another important aim of the tool is to assist you to identify deviations from normality and to help you identify when this deviation may need additional care or refer to another provider or, for example, a higher level facility. And in this sense, it will also help you to prevent unnecessary use of interventions, such as, for example, augmentation of labor. And finally, it should also enable better auditing and quality improvement in your facilities. So for whom, when, and where can you use the labor care guide? So it can be used in all pregnant women, regardless of their risk status. Although, as we have mentioned it before, the tool was mainly designed with low-risk women in mind, meaning that you might need to adapt your monitoring and the actions that you take depending on whether you have identified any risk in the woman or the baby. So when do you start to use it? So the SDG should be started when the woman enters active phase of first stage of labor. And we have had a lot of discussions in the last 2 webinars around this change in the definition of active first stage of labor. So this means that it starts at 5 centimeters or more of cervical dilatation. And this is regardless of her parity or membrane status. The SCG allows you to continuously monitor the woman during active phase stage of labor and second stage of labor, and it can be used at all levels of care in health facilities. Also, the plan of action might depend on where you are, the level of the facility where you are working, and also the resources that you have available to manage complications if they arise. So let me go quickly through the structure of the SCG. And I know that you know this already, right? So the SCG has 7 sections. Most of them have been adapted from the previous partograph. Some of them are new, and I will come back to that in 2 slides. So there's a first section that allows you to identify the woman and labor characteristics. The second, I'm trying to put that, okay. The second sections is around supportive care throughout active first and second stage of labor. Third and fourth sections are around care for the baby and the woman, and they may look at vital signs and then fetal heart rate and fetal position, amniotic fluid for the baby. The following section, section 5, is around labor progress, and it is here where some of the changes were introduced. not in the way we monitor labor progress against time, but mainly in terms of the limits that we use to trigger action or to define prolonged labor. Section 6 is around medications, and Section 7 allows you to record a summary of your assessments and then a plan of care. And the LCG includes an alert column. So for most of the variables that you will be recording in the tool, there's some alert values that are proposed. So you can identify when there's any deviation from what you would expect as normal, and allow you to then, as we discussed in the previous webinar, circle any deviation from normality and then assess and plan accordingly to your findings. We published the SCG with an user's manual. So this manual will allow you to complete the LCG, and is primarily targeting an audience as you, so skilled health personnel, providing labor and childbirth care in any settings. And the manual is available online, and we have shared also the links with you, so you should have it already. I will now go through two slides that will highlight what are the similarities, but also the differences between the LCG and the WHO modified partograph. So as a reminder for all of you, both tools have a section that allows you to identify the woman and, for example, how labor was initiated, time of rupture of members, and these variables. Both tools allows you to record maternal and well-being, and also babies' well-being. And in this sense, some of the variables are different, but a lot of them remain the same. Mainly the main difference here is the way you will record your findings. Being in the LCG, actually the findings that you have during your assessments will be recorded in actual numbers, whether in the partograph you needed to plot them, for example, for fetal heart rate or pulse or blood pressure. Both tools have a section around medications, and these have remained basically the same, as well as a section to record labor progress and contractions, where, as I already mentioned, the thinking behind and that measurement of cervical dilatation against time is the same, but based on the current evidence and knowledge that we have around labor progression, we replace the alert action lines for more evidence-based values to for women to move from 1 centimeter to the other between 5 and complete cervical dilatation. So now looking at what is different, or the new sections that we have in the LCG, these are mainly 3. One that allows you to monitor and record your findings around supportive care. The section at the bottom that around shared decision making to record your assessments and your plan, and an additional section that is the column at the right that allows you also to monitor the woman and the baby during second stage of labor. So in summary, and to allow me to introduce you to the next part of this webinar, the SCG aims to support you implementing the WHO recommendations on intrapartum care. We will be discussing later today how this tool was developed, but it needed a lot of research, knowledge synthesis, consultations, field testing, and a lot of interactive revisions of the tool until we got to the version that we have been sharing with you. And this whole process included a lot of midwives. The last part of the research that we did is a pilot study in 6 countries where we identify a number of facilitators for implementing the LCG, but also some of the barriers or challenges that we can find as we will move forward with implementing this tool in practice. And this is what we would like to share with you today during the conversation that we will have with different midwives that were involved at different stages of developing this tool. So thanks for joining for this last webinar, and I will just pass over to Muna and Fatima to take us through the roundtable. Thanks.
Thank you so much, Mercedes, for highlighting the most important parts which we have discussed in the past 2 webinars, and people are still asking some questions. And maybe before we start the roundtable, once more, if you can clarify, Mercedes, why we moved to 5 centimeter and not 3 centimeter. And some people are asking if those people who missed part 1 and part 2, how they can access this platform and WCA. Maybe if you can say a few words, and then we move into the panel discussion.
Sure. So for the second question, I think that we could maybe provide more information on the chat box. I might not be the best here to tell you how to access those, but I'm sure that this will be available online, so you will be able to see the recording or follow the course online. Just coming back to the question about the change in the definitions, this change is based on systematic reviews that we conducted, and then the recommendations that are included in the WHO 2018 document on intrapartum care for a positive childbirth experience. And what those reviews found is that it's only from 5 centimeters that labor really accelerates. And we were able to also, looking at different studies, establish what is the median time that women usually need to move from 5 to 6 or 6 to 7 and so forth centimeters of cervical dilatation. And all this in women who at the end had good perinatal outcomes, so both for themselves and also for their babies. So if you go to the guideline document, you will find all the details about the findings of these reviews. And I could also share the publications that we made and for which and that we use for these recommendations.
Thank you so much, Mercedes. And now Nancy have already introduced to the panelists, and good afternoon and good morning to you. Thank you very much for joining us. We have here over 400 participants online, and some of them will join us later. I'm sure as previously we have over 800 participants. So as you can see, we have a very interesting panelists from all over the world. We have Veronica from Argentina, Rose, Prisca, and Angela from Tanzania, Violet from Malawi, Tina from UK, and Caroline from Australia. It's so very global representation, and with a rich experience in terms of developing and implementing this, testing this LCG. Let me just, myself and Fatima, our colleague from UNICEF, will facilitate this roundtable, and while we ask a few questions which we think will be common questions, but at the same time you can post your questions directly to the panelists, and we can see how the panelists can handle the questions. So I will ask Professor Lavender if you were involved in different stages of this process of developing and testing the LCG. Could you please tell us more about it, about the testing and the process of developing this LCG?
Yes, of course. Good morning, everybody. I'd be delighted to share with you some of my experience. As Mercedes has said, the WHO Labour Care Guide is a new tool developed to facilitate implementation of the intrapartum care recommendations. And so far it's gone through a development process, which has been an iterative process of evidence gathering and revisions, and based on a considerable amount of research, knowledge synthesis, expert consultations, and also field testing. And this included 3 studies using the first version of the Labour Care Guide. It also involved initial discussions with midwives from Sub-Saharan Africa during the Lagina African Midwives Research Network, which was held in Malawi at a conference, and a rapid classroom usability study with obstetricians in Brazil, and also an international online survey with a range of maternity care providers.
Thank you so much. Is the tool being used now?
That's a really good question. No, the tool is not currently being used. It's a new tool, but it hasn't been introduced into the countries yet. So what we are actually sharing with you today is mainly our experience from the studies that we're all involved in to test its usability, its acceptability and feasibility. And there was a study that was done in 12 health facilities in 6 countries across Americas, Asia, and in 4 countries in Africa, which was Kenya, Malawi, Nigeria, and Tanzania. And during this study, we trained 136 providers, from which 2/3 of them were midwives. And they used the Labour Care Guide in over 1,200 low-risk women, supporting their births. And after that, we had focus group discussions with the providers and asked them about their views on using the Labour Care Guide, and also to suggest improvements to the tool, and also to give feedback on the training materials that were used. And based on these studies, we revised the LCG again and the user's manual before it was published last December.
Wonderful. This is really substantial study. Can you tell us more about some of the results of this feasibility study? Were providers able to use the LCG, or were there challenges?
Yeah, absolutely. I mean, obviously, when anything new is introduced, then people are apprehensive. and that was the case with this. But we found that the results were very positive, and overall providers agreed that they could use the labour care guide and were able to complete it correctly. And this was true in more than 90% of all the women they supported during labour. We also looked and found no difference in experiences and satisfaction across the countries or across different cadres. For example, there was no difference between abilities and experiences of midwives or obstetricians. It was also reassuring to see that health providers' experiences improved as they attended more births using the LCG. So their confidence and their ability increased the more women they supported in labour.
Thank you so much. I will hand over to my colleague Fatima on the panel discussion.
Thank you so much, Mona. Thank you so much, Tina. That was really enlightening. Now, we would like to know more about the scope, aim, and comparison of this LCG with the previous partograph. And I would like to ask from Veronica, it is good to hear that during your study, providers were satisfied with LCG. Does this mean that LCG will replace partograph or partogram, or will both be used? Veronica?
Yes, hello everyone. Thank you for the invitation. And this is an interesting question. The labor care guide was developed to replace the partograph. So we reviewed this in more detail during the last webinars, but now we know that the labor care guide incorporates up-to-date WHO recommendations for labor and childbirth care. And this includes considerations to improve experience of care, as well as the new understanding of the individual variability of the progress of labor. So yes, the labor care guide replaces the partograph. And we also discussed this before. During the last decade, it became more clear that the evidence couldn't support some components of the partograph. So in 2018, when the recommendations were updated, it became evident that the partograph required a revision in order to be aligned with scientific evidence and also with a broader approach for labor and childbirth care, an approach that would include women and families' experiences. So the labor care guide is the monitoring tool that replaces the partograph. We are not expected to use both, but only the labor care guide, since this is the tool that was designed according to the current scientific evidence and also the current model of care.
Thank you so much, Veronica. And yes, again, another reassurance from your previous discussions also that it has replaced actually the partograph. And so now I'm really curious to know then how different LCG is from partograph.
Yes, so the labor care guide is definitely different from the previous partograph in several points. But at the same time, it retains a lot of the same concepts and content. So the labor care guide is a tool that will allow you to monitor women and babies during labor, and you will record your findings, including all the clinical parameters that we are used to record in the previous partograph, as well as the duration and frequency of the uterine activity, the cervical dilatation, the fetal descent, all these parameters against time. However, now we know that the approach to labor duration is different, as we have shown in the previous webinars. That's an important difference. And we also know that the labor care guide includes triggers for all the different sections that we find in the alert column. It also put a lot of emphasis on respectful maternity care, including monitoring and recording of practices related to supportive care. It also includes the monitoring of the second stage of labor, and it allows for recording a plan of actions based on shared decisions. So there are some key differences, but at the same time, there are many other concepts and components that were retained from the previous paragraph.
Thank you so much. If my takeaway is there's a difference in approach, and which we discussed in length in previous webinars, and also it has trigger points, and then it also includes respectful maternity care, monitoring of second stage of labor, and the one thing which I really like is plan of action for all stakeholders, all shareholders in whoever is making decision for the women and newborn. They all are involved in it. Thank you so much, Veronica. Over to you, Mona.
Thank you, Fatima. And I think let's come to this region now, and let's hear from our colleagues from Tanzania and Malawi. Prisca, we have heard that LCG is going to replace partograph. So the question is, what did the LCG help us to do, which partograph doesn't? And what was easy about using LCG when we compare it with partograph? Prisca?
Okay, thank you. When you compare the previous partograph with the LCG, first of all, for us which we have already practiced, it's need time for the midwife to get an experience. For example, if they can make it like training, it's more easier for us because it saves a lot of time when you compare it to the previous partograph, because it's very short and precise, and it summarizes a lot of issues, and it gives us full time to be with the mothers and to monitor also their babies intrauterine.
Okay, wonderful. And Prisca, if you also could you tell us more about how LCG may impact the quality of care we provide?
The quality of care which we provide, it recognizes the value of supportive care. When we were using the previous partograph, it has no component of supportive care. So for this LCG, it recognizes the value of supportive care, especially when the woman, it will be there. Each and everything you can share with the woman, and you can make the decision together. Even if they have any relative coming with her, you can share those activities. And also good things, it's a reminder of a clinical practice. It reminds us as a midwife, what are the things which we are supposed to do to the mothers, because the partograph, it has each and everything. What you need is to go through that systematically and to see what are you supposed to do, which you didn't do it. So if you go with it systematically, it reminds you things which we are supposed to do. So it makes it very systematic.
I think, this is a very important issue. Prisca is telling us about the experience of care, about the supportive care. And as we know in this region, we are lagging behind in terms of respectful maternity care and the experience of care. And I think this LCG would bring, along with other good features, that to bring attention on experience of care and supportive care. And thank you so much, Prisca. And I think we also learned that it's much more easier than the previous partograph and much more systematic and provide guidance as well towards clinical practices. Thank you so much, Prisca. Fatima, over to you.
Thank you so much. And now, sorry, Prisca. Thank you so much. So now I would move on to our next panelist, Angela. Angela, as Prisca just mentioned, that the new section of LCG and how it helped you to provide better quality care. And then there is another new section at the bottom of LCG. And okay, so it's in a nutshell, the question is about, did the labor care guide inform your decision-making during labor? Can you share any example of cases where the labor guide informed your decision-making? Any example, Angela?
Okay, thank you. Yes, the LCG inform about decision-making during labor. For example, it helps on early detection of deviations from normal, and also it reduces the use of unnecessary interventions. Yes, thank you.
Okay, thank you, and thank you. So now I would deviate my questions towards some of the challenges which you may have identified. So I would like to know if using the labor care guide made it more difficult to do anything that you would normally do. What was the challenging? What was challenging about LCG implementation?
The challenges about using the LCG was it needs special attention to changes in the recording, also checking with the threshold and circle observation that meet the criteria in the alert column. Also duplicating of the records.
Okay, so if I may ask a question in continuation, how did you overcome those challenges, the one which you identified?
Yeah.
So if I may, okay, let me rephrase my question.
Yes.
So we are saying that so if you're saying that LCG may not have enough space for clarification, are you suggesting that additional information should then be recorded in the medical records?
Okay, yes, the LCG is not meant to replace the medical records. You can record additional information in the medical records. Also, you avoid duplication.
Okay. Oh,
yes.
Okay. So it means it doesn't really replace medical records have their own strong space, and we should keep on recording them and should not duplicate the information. Excellent. Over to you, Mona.
Okay. Rose, let me come to you. Rose, you have been with us in the last part 1 and part 2 LCG guideline, and you gave us a lot of exercise, practical exercise. And now my question to you is, does, you know, Angela has discussed about challenges and possible solutions. Does this apply, for example, to high-risk women? My understanding is that the LCG was primarily designed for uncomplicated women. Can it then be used in high-risk women also? Rose, can you hear me? We can't hear you.
Mute? Well,
yes.
We used it to normal women, but yes, the LCG can be used in case of the women who has complications. For example, you know, women with risky conditions, for example, diabetes, for example, those with preeclampsia. Actually, I think it will be the best to use this because you can detect them earlier. And these risky factors may influence the care. And hence, since the quality of a labor care guide is to help women and midwives to make decisions, so using it with LCG during using LCG with women who are in labor but at the same time have complications, it will help them in recording better in the first section, and then the same condition, such as those I mentioned, and also multiple pregnancy or breech, where they may first evaluate whether a vaginal birth is possible or not. So this tool can be used. The priorities of labor monitoring apply. A priority for clinical judgment, as I said from the beginning, can be adapted, and the thresholds, frequency of monitoring, and the plans at the last stage. So using the medical records to document additional relevant will also continue. So,
Okay.
I can say yes.
Thank you, Rose. And another question, sorry, for you is, sometimes when we are overloaded with so many things to do, we forgot to complete the partograph, and we complete the partograph afterwards, so after the baby is delivered. And so this has been a challenge, but is that stuff would I think that the LCG, by including a section on shared decision-making, is looking at addressing this problem. Is that correct?
Yeah, this is very correct, because the fact that we have to complete and plan after each assessment, this gives a great value. It was very helpful when midwives were using it, because it continues to the last section 7 and 8, where you are forced to complete that LCG, unlike partograph.
So which means it's also a planning tool, isn't it? After you complete one section, you plan for the next.
Yes.
Okay. Rose, one more question for you before we move on.
It is required to document a...
Say again?
Sorry, I didn't hear.
Okay.
Repeat the question.
I thought I have interrupted you. Okay, let me ask you the last question. What might make it, what might make it difficult for labor ward staff to routinely use the labor care guideline?
I think one major concern across many sites and our sites is the heavy workload. We talk of heavy workload since then, so it also includes labor ward personnel. There are few, so having to document quickly, attend another woman, that makes it difficult. But then when we use labor care guide regularly for all women in the labor ward, it can be time consuming at the beginning, but then providers will have also ability to later to overcome the workload, because women will not stay longer. It will save time by not performing unnecessary interventions. And since women will be decided, the decision for women will be early and no unnecessary intervention. That will save time. Ultimately, it will save their workload.
Thank you so much, Rose, for sharing this experience from Mwanza, from Tanzania. It's very helpful, for those countries who are contemplating about initiating this LCG. It's very useful to have your experience. And colleagues, if you have also the questions to the panelists, please post it on the Q&A, and we will ask the panelists to respond to your questions. Fatima, over to you.
Thank you so much, Mona. So now I would move on to our colleague Violet, next panelist, and my question to you is to adhere to some of WHO's recommendation and be able to provide the care that needs to be recorded in LCG. Some basic resources are required. So, for example, division in the case of shared delivery rooms so that companions can be present. How can we solve this issue?
All right, thank you. access to basic equipment and supplies that are essential to complete the LSG could be a barrier in some cases. For example, due to unavailable non-functional equipment and supplies, providers reported that they needed to be selective about which women they use limited equipment and supplies with. But also there were issues around ensuring timely and safe referrals to women in labor. And just specific to your question about labor companion, we understand that this is one of the other supportive interventions where a lot of things have to be to come into play to be able to provide it, if not in place. But as my colleague previously mentioned, I think no one probably wants to fill the supportive care section with no. So the LCG should help to raise awareness about some of these, and that something has to be done. And we may recall that WHO published last year an evidence to action brief on companion of choice. And awareness on one of the factors is one of the factors that are known to help with implementing companion of choice in maternity units. And other factors that may help then having a policy that is supportive to this practice, including local protocols and optimizing the physical structures. And I think that getting support from managers in our facilities is the first key step. And then maybe people haven't seen the published the evidence to that was published on Birth Companion, then we can share a link in the chat box to link them to the document.
Thank you so much. Thank you so much, Violet. You have raised some very pertinent point, especially linked to the advocacy awareness. So the tool is even helping us onto that. And I feel like through LCG, we are institutionalizing respectful maternity care, which are very much things which you're talking about are very much part and parcel of the standards of maternal and newborn health care also. So it's so good to know that the tool is helping us with that for the implementation. Excellent points. Thank you so much. So my next question to you, which is also, it's a very practical question, and we've been facing that problem even with with Partograph also, is about the consistent use of LCG. How can we make sure that our providers are consistently using it during their routine practice? Violet?
All right. Maybe first, it is important to give time for skills acquisition. Providers may find the LCG initially challenging, and as my colleague already mentioned, they may need some time to familiarize with it. So, more time means more practice and also competency. So they really need more time so that they become competent in using the LCG. But also, one other important thing is that providers may need support and feedback. Most of them had reported to say that the feedback on completed LCG was valuable way of learning and how to complete the LCG, as well as an important source of motivation. So providers consistently reported that receiving feedback on completed LCGs had supported their learning. And for example, some of them said that after 1 week of using the LCG, we should have like a session for half an hour so that our difficulties can be discussed and then we can report them. Then that would reduce more problems. And further to that, our experience also showed that the LCG supports teamwork and handover. So providers reported that the LCG can work very well to support handover, in particular when handover is focused on information from the assessment and shared decision-making sections, and not only on the alerts, as we know. It also helps the providers and teams record their plan of action, either when labor is progressing as expected with no complications or when complications arose.
And this needs to be a shared responsibility for both nurses, doctors, and anybody, so that we can support and give feedback to the providers.
Thank you, Violet. Thank you so much. You have raised a few more additional important points, which is shared decision-making, shared planning. So it's not just the entire responsibility of nurses and midwives, but doctors also, they have to be involved in it. Your point on the job coaching, mentoring, this should be a permanent feature of health facility, not one of ad hoc trainings and teamwork. Thank you so much. Over to you, Mona.
Okay, and maybe it will be good to know more about training and staff skill building in the implementation of LCG. I will go back to Prisca. Prisca, how long did it take you to feel comfortable using the LCG? And if you can tell us more about training needs.
Okay, thank you so much. You'll be more comfortable using LCG. It's needed to sometimes to practice. You can have maybe 3 to 4 cases so that you can be very quick, about 10 to 15 minutes after practicing and after being trained and given skills how to go through with this LCG. Also, there are more of practice, I said, because when we practice for the first time, people, they think that it is more difficult, but as this LCG, it is go systematically. First of all, you will start with supportive care. What was the baby doing? What about woman, progress of labor, medication, and shared decision making. So the more you practice, it is more easier than when you compare it to the photograph which we are using about the cross line, transferring it. So for this one, it is straightforward.
Thank you so much, Prisca. And maybe let's go to Australia. So Professor Caroline Homer. Caroline is very much closely work with UNFPA in terms of support for midwives as well. And thank you for joining us today, as Caroline. And my question for you is, from your experience with the pilot study, what would be needed in terms of training of providers in health facilities?
Thank you, Muna, and thank you to WHO for inviting me to participate. I'm very impressed with the level of questions coming from the colleagues, more than 550 colleagues mostly from Africa. So a huge welcome to you all. So in relation to your question, Muna, about training, and Prisca's just mentioned a bit of this, but we asked providers who participated in the pilot study about their thoughts on the training that they received around the LCG and how we could better fulfill their needs in this sense. And midwives and doctors in that study told us that initial and refresher training was key as the LCG is introduced in practice, and that training should include a strong practical component. And you've just heard Prisca's example of filling in the LCG using case scenarios, as well as an example of filling in a sample LCG with the women in labour during training. In general, providers suggested they would need maybe 2 to 3 days training, including the more theoretical training and practical skill building. And that would be focused on taking the measurements required for the LCG and trialling the LCG in labour. I've seen lots of questions around the sort of theoretical underpinning underneath the LCG, particularly the 5 centimetres and active stage. So it's important that the midwives and the doctors have all read the information on the intrapartum care guidelines before the training, because otherwise it'll take a long time to get through that part. In the trial, in the study, providers said that refresher training was really important for health workers as they learned to use the LCG. And I think you will agree that refresher training is important for all midwives and doctors on everything, but particularly when you have something new. And when we asked providers on how often they should have refresher training for LCG, that varied, but they generally thought that the frequency could decrease over time. So you might need quite a lot in the beginning, maybe for the first 6 months of using, and then it could go to more of an annual update, maybe every 2-year update, once everybody is using it and using it well. So we also asked about the materials and modalities of training that they would need or like to use. And we did this study before COVID time when everything was done face-to-face. So maybe in this little time now, we can do a little bit more of distance, of online, as well as the face-to-face. In general, the providers we asked found the user manual really useful and highlighted that some local adaptation would be important, and we can come back to that a little bit later on. So I think distance training may not be effective for practical training. So I think the distance training, just like we are doing in this session, is really useful for giving information. So providing information and providing knowledge. But to actually get the experience in completing the LCG and the experience in the interpersonal engagement that is required to move everybody. This is a paradigm shift among providers towards woman-centered labour care, respectful maternity care. This is a big shift. We've been using the partograph all of my life as a midwife, which is 30 years, I've been using the partograph. And so now we need to use something different. So it will just take a little bit of time and we need to be patient. Thank you.
Thank you, Caroline, for that advice and reminder also, you know, it takes a long time to shift paradigm from using partograph to using LCG, and we have to be patient. And as we have seen in the last 6 weeks, actually, in 3 parts is questions have been asked over and over again because of, I think, we have been using partograph for so long, and we just can't really take in all these changes now coming. But I think as we go along and practice, and when we see the use also, we have to be patient. Thank you for that. And you talked about adaptation, Caroline. Can you tell us a little bit about LCG adaptation at national or facility level?
Yes, of course, Muna. So the LCG can be and should be adapted to local context. The world that the context that you all work in is very different from community, primary healthcare units to tertiary, to big cities, to small towns. It is all different. And so you have to be able to adapt. So the LCG has been developed to align with the WHO recommendations on intrapartum care for a positive childbirth. And that report, those recommendations were released in 2018. And I think really important for every facility to download and to print that document and to have it in your labour wards so that you can refer to it all the time. But we do know that some adaptations to the LCG may be needed to reflect your local practices and, of course, your resources. We have had some examples, for example, some specific information that might be reported in the medical record or is in your current version of the partograph and that is missing from the LCG. So issues like maternal HIV status, maternal blood group, and rhesus status should be included, but you may need to use your medical record, as we've said before, rather than the partograph. And in some countries, you use different clinical references to assess fetal descent, for example, by vaginal examination instead of abdominal palpation. And sometimes you will need to adapt that so that depending on what you use in your practice, you can change. I would like to just put a caution, though, around adaptation, that be careful about the adaptation, that you are not taking out the things that we know are effective from the evidence. So it's no point adapting the LCG to make it look like the old partograph or the current partograph. That's not the point. The point is that the evidence has been looked at And we now have a new way of thinking about labour care and labour monitoring. So we can't adapt to the point that it just looks like the current pantograph. So some things I know will be difficult, and we've already mentioned some of the things that are difficult in your labour wards, and companion in labour is a particular example. And it's not okay to just take that out because that's adaptation. You need to leave it in, and as our colleagues have already said tonight, you need to use that as advocacy to enable really important interventions like companion in labour. Thank you, Muna.
Thank you, Caroline. I have more question for you. Thank you for sharing this important advice and experiences from your over 30 years of experience and engaging in this development and study of LCG. What are other key elements in the process of adaptation of LCG should include? If you can say a little bit more about that.
Yeah, so adaptation is not only, you know, in your labour ward, we also have to have a wider engagement. So I guess perhaps there are three key elements to consider. First, engagement with national and local experts, healthcare providers, of course, the midwives, the nurses, the managers, the policymakers. A group should come together to review the LCG in light with your national and local standards and guidance. And this is where you may need to update other policies and protocols to include the WHO recommendations. It may not be that the LCG is the only thing that you need to think about when you look at the intrapartum care guidelines. So really important to have that high level leadership from your managers, from your policymakers, from, if you're a midwife, from your obstetricians, if you're an obstetrician, from your lead midwife. So a really important group. Secondly, as you're piloting in your clinical setting, as you roll out your training and your adaptation and your piloting, encourage feedback. Have some feedback sessions with your colleague midwives, your nurses, your obstetricians, your pediatricians. Find out for them how it's going. You might be surprised how much you learn from this process about how best to use the LCG in your facility and whether you can make the changes make sense. And I think it's also an advocacy tool because you'll be able to start saying, well, we need something different. We need to do something different. We need some different ways of thinking about labour care. And my last point would be to keep the LCG as concise and focused as possible. We had maybe a year of discussion to try and get it onto the one page. Many conversations to try and keep it concise and focused. And it shouldn't be everything. It should be just about labour monitoring and early identification of complications. And you can't add everything. It is not a new medical record. It shouldn't duplicate. You shouldn't have to repeat what you've put in the LCG into the medical record, but please don't try and add too many new variables or sections because then it will just be 3 or 4 pages and it will be too hard to fill in. So keep it concise and keep it focused.
Thank you very much. Very clear guidance on the adaptation, very useful. And this webinar will be recorded and will be available to you also for you to revise what's been said so far. And the last question for you, Caroline, is are there plans to conduct further evaluation of the LCG?
There are, Muna, yes. And at the moment, I imagine there will be a number of studies, but we are currently involved in a very exciting study in India being led by my colleague, Associate Professor Joshua Vogel, who also led the pilot study that we've been talking about. This new study is a randomized pilot trial in 4 maternity hospitals in India, and we're looking at how the LCG might reduce cesarean section rates and improve quality of care during labour and childbirth. And we're working with local stakeholders in these 4 hospitals to adapt the LCG, to design an implementation strategy, to design a training program. So the conversation we are having tonight and the questions you are asking are really useful in terms of designing a training program. And we hope that this study will provide some more evidence, some more information and tools to help the implementation. While I said, I'll just say one more thing, Muna, while I said earlier that we have to be patient and it will take some time, it can't take many years. Very often when we have a new intervention or a new strategy, it takes 10, 20 years to get into practice. We can't do that. So while we have to be a little bit patient, it can't take many years. The mothers and the babies we look after cannot afford us to wait. They cannot afford for us to spend a long time. So I encourage you to get started. And I think having 570 people on this call is evidence that you really want to do that. And I really admire you for doing that and wish you well. Thank you, Muna.
Thank you so much. And a very strong message. We can be patient, but not patient long enough to let mothers and babies die unnecessarily. And I think from our region especially, there is a huge interest for midwives and nurses. And we have also planned for in the future to engage OBGYNs and medical doctors. But I think patience, we have also very limited time, and thank you for that strong message. Thank you so much. Now I hand over to Fatima or Nancy.
I think we will, yeah, just thank you so much. And again, it's a paradigm shift. It is, it needs a change in our thinking, in the way we are doing our routine work. And we need to, and one message which I would like to again re-emphasize from Caroline is we need to adopt the tool, but without losing its essence. So that's a message, a take-home message for me also. But thank you so much. I think on the other parts, Nancy will lead us. Nancy, over to you.
Just one more thing, maybe if there are a number of questions before we lose the panelists, can we ask a few questions?
Yes, and I think Mercedes will help us with that. Right, Mercedes?
Sure. So do you want me to ask the question or?
Yes, Mercedes, please proceed.
Yes. Okay. Okay. So I will try to direct the questions to the different panelists, but please, all the panelists feel free to complement anything your colleague said. And I try to lump the questions so they, so maybe one first question will be for Tina, and one question is around the gaps that have been identified in terms of using the partograph and how this has been taken into account as we design the LCG. And if you could tell us more about how LCG might help us with filling those gaps.
Okay, thanks, Mercedes. Yes, of course. First of all, just to say that, you know, the partograph, when it was first introduced, you know, was extremely innovative and, you know, still has many positives. But in many settings, it hasn't reached its full potential. And, you know, we've learned more and more as, you know, there's been additional research. And, you know, if you look at the Cochrane review, which has compiled all the evidence of trials, you can see that there isn't any strong evidence that that the existing partograph actually improves clinical outcomes for mothers and babies. So this is a foundation on which we need to look at how do we improve practice. And I think that, you know, from the previous research and even from our own qualitative work when we've been looking at the Labour Care Guide, there was concerns about the existing partograph perhaps not promoting individualised care, which as midwives we all know is extremely important. And I think that the elements on the new Labour Care Guide address that in several ways. I think that firstly, it by allowing for the different cervical dilatation on admission to be taken into account, actually acknowledges the different progress of labour for individual women. Also, I think that the inclusion of the supportive elements of care, like companionship and positioning, are really important and elevate the status of these, which we know are extremely important parts of labour. And I think thirdly, it's about including the need to plan, because although the existing partograph, the expectation is that you use that as a prospective tool to plan. In reality, in many cases, that didn't happen, and I'm sure that many of you online will acknowledge that. But by having the planning bit on the Labour Care Guide at the bottom, it means that people are prompted to do that, which again supports the individualised approach for women in labour. Thank you.
Thanks, Tina. That was very clear. And one question related to that, and I think that it wasn't probably clear enough from our explanations, is around how the LCG and the medical records complement each other. So if I could ask Rose maybe to elaborate a little bit more on that point, on the duplication of efforts and the duplication of recording the same information in the LCG and the medical records, and what is on our side the approach, and or for example, if you can give us, Rose, an example of how you deal with this during the pilot study in Tanzania. Rose, we cannot hear you.
Yes, I'm saying this is a little bit tricky question, but the duplication, for example, we had to fill all the principles of following labor monitoring are there. But as people have said, for example, the space might be very small to fill some important issues. So, despite every woman will be having an LCG, at the same time, the woman is having records, the file, our own personal file, which will include all other issues. For women who are maybe at risk, if I could approach that way, you need to have more information, and these cannot all go to the Labour Care Guide. So, as we said from the beginning, the Labour Care Guide does not replace patient's file, but the Labour Care Guide is a systematic tool to give us decision making. So the planning part, for example, you write there in short, but then if you need more, to put more, even the treatment part, you'll put there in short, but you will need to tell them more in the patient's records. That's how I can say. We could write, for example, a section on medication. That is short, but then the medication are well elaborated in the patient's case note. So it's a bit of duplication, but with a purpose that will give you a good decision making on the benefit of the patient. That's how I can answer.
Thanks, Rose. And
over to you.
Thanks, Rose. So you mentioned that last section in the SCG where you can record your plans and also the medications. There's a few questions around that shared decision making section. And I would like to ask Violet, how you use this section in Malawi when you were testing the LCG. The questions that we have are around, okay, it's a shared decision between who and who. Can you give us an example of how the woman participated in those decisions and how you can incorporate that individual care plan in the LCG?
Sorry, I lost connection, but the shared decisions would be among the midwives, doctors, the labor companion, and the women themselves. So whatsoever you do on the patient, you need to discuss with them. For example, like in our labor ward, we allow birth companions. And suppose a woman comes in labor without a birth companion, you would ask them why they don't have a labor companion, because ideally you would see that they should have one. But based on their reasons of not having a birth companion, midwives would explain to them the importance of having such a companion, and later on they would make a decision, help you, give you contacts of their companion of choice, and then you'd call them so that the care that is supposed to be done by the companion is not compromised.
Thanks, Violet. That was really very clear, and I think that your example is one that a lot of midwives wonder how to put in place, and you clearly show that it's important to consider also the women's decisions in that sense, and allow her to have a companion if she wishes so. There's a question that I think that is very interesting, and Caroline, I'm sure that you can answer this when it's related to the shared decision making, and is about whether SCG is only for midwives or is also a tool that can be used by obstetricians and other providers.
Thank you, Mercedes. My view is that the labour care guide should be used by all the providers caring for the woman in labour. So a midwife, a nurse, a doctor, in whatever the cadre is, the guide should be used. So the way I think about the guide is it is attached to the woman, not attached to the provider. So it's her labour care guide, not the provider's labour care guide. So if you think that each woman has a medical record and each woman has a labour care guide, then whomever provides care to her should complete that labour care guide. I think the whole concept of shared decision-making is, for many of us, a new concept. Essentially, it is a decision-making between the provider and the woman. So the provider, whether it's a midwife, obstetrician, nurse, pediatrician even, and the woman and her support person. And I think this is a new space that respectful care and listening to women and woman-centered care, we are talking more with women about what we are doing, what we are suggesting, what we are recommending, and what they want, and how to ensure that they have a positive experience. Does mean that women have to feel a sense of control, and that we have to give them some control and some choice in what is happening. And you know, that supportive care aspect in the LCG, I think, is really important part of that shift towards shared decision making.
Thanks, Caroline. I think that what you just said about the SCG is a tool of the woman and not of the provider is very important, and it certainly will help with providing woman-centered care, or I hope that it will. We also have a few questions around using the SCG in particular situations. And Veronica, maybe you could answer these questions. So they are around, for example, using the SCG in case of preterm labor. What about women who had previous cesarean section? Could you please tell us how the tool was developed and whether we can use the tool in these cases?
Yes, thank you, Mercedes. So the labor care guide was mainly developed for women with pregnancy with low risk of complications, but actually all the monitoring principles and the parameters that are included are usually the ones that we use to monitor all women, regardless of the risk, if they are low risk or high risk. So actually we can use it among all women, low and high risk. What we need to probably take into account is that we will need to adapt some components of the labor care guide to each clinical case, to each individual woman. So mainly if we are monitoring a woman with a high risk of complications, the thresholds might be, we might change them. We might react earlier, depending on the case. The frequency of monitoring might change as well. And probably our plan could change. So it's not that we can't use it. We can use it actually with all women, but we have to, be very, we would need to apply our clinical judgment to adapt the frequency of monitoring, the thresholds, the plan, and there will be more variation compared to women with low risk. And in terms of recording, we can still use the labor care guide to record most of the clinical and non-clinical parameters that we are monitoring. But in these cases, it's almost for sure we will need to add additional information in the medical records to clarify in more detail what is our plan and the decisions we make with these women.
Thanks, Veronica. So maybe I have two other questions for you. One question is why there isn't an alert for descent, and how this design findings should be interpreted. And the second question is if we allow women to have longer labors, sometimes we probably might need to open a second LCG. So how people should add when this is the case?
Okay, yes, those are really good questions. And actually, that's correct. There are no thresholds included in the labor care guide for fetal descent, although most of the parameters have thresholds that we can use as reminders, and we can always check to compare to our observations. But in fact, we don't have those for fetal descent. And first, we know that, it will be hard to standardize thresholds in terms of fetal descent, it will depend very much on each individual case. And the decisions that we make, it also depend a lot on some other parameters. And here we always take into account caput molding, the cervix characteristics, the status of the membranes, and even when it's necessary, our assessment of the pelvis. So there are no thresholds, and actually there's no robust, strong evidence available in order to standardize threshold for fetal descent. So these will be mainly based on each individual case, and you will have to take into account many other variables or parameters in order to trigger actions or to make a decision when to intervene in the progress of labor. And for the second question, if the woman exceeds the 12 hours, labor lasts longer than 12 hours, we will need to start using a second LCG in order to continue monitoring. We know that most women will, their labor won't last that long, but that's the average. So there could be some women that take longer, and in case all the rest of the parameters, the maternal and the fetal parameters, remain normal, we know now that it could take longer, and that is safe in terms of the prenatal outcomes. So if needed, if the woman exceeds the 12 hours, it is recommended to use a second print labor care guide to continue monitoring and documenting our care, the care we provide.
Thanks, Veronica, and thanks all for all of these answers. I think that they have been very helpful in clarifying some of the questions coming from the participants. So I will take the last questions that are more around, again, the changes in the definitions, and some of the questions are around, well, WHO is recommending now more context for antenatal care, but then you're telling us that we don't need to monitor a latent phase, that active phase is starting late. So it looks like a bit contradictory. So can you elaborate on this? And how, for example, or what should I do during latent phase? So we have covered these questions in the last webinars, and we completely understand that this is a major change in the way we look at labor, and we define the different stages of labor so far. So we know that all these changes are not easy to digest, and I think that it's good to see these questions coming over and over again, because it means that we also need to ensure that we provide you with the tools to understand why all these changes, right? Just because the ANC recommendations were mentioned in one of the questions, or the increase in the number of contacts that are recommended now by WHO, and that are mainly at the towards the end of the pregnancy, were mainly recommended for the prevention of stillbirth. And it is, I think, not contradictory to also tell you that we also look at the evidence on how labor progressed in women who had good outcomes at the end of that labor. And as I said at the beginning of the webinar, what we see from that evidence is that it's only from 5 centimeters that you can really see that labor starts to accelerate. And what we know from previous studies, including studies, for example, that look at the partograph when the initial WHO partograph also included, for example, a latent phase part, is that if you start recording all these different parameters in your tool too early, that will result in increasing some of the interventions, either augmentation, or it will end up increasing your cesarean section rates. And it is basically for the same reason. Up to 5 centimeters, there's huge variation in how women progress. It is very difficult to define when labor starts and what could be called a prolonged latent phase. So if you look at the recommendations from WHO, what we say for latent phase is that it is very difficult to define and to give a time span for that period, and that you should inform women about that. And that is only from 5 centimeters when you will really start to monitor her more closely. It doesn't mean that you don't have to monitor her during the latent phase, but more closely throughout the active phase. And it is when we have clear evidence that allow us to have these timings and be able to define what will be a prolonged active first stage of labor. So with that, I will pass over to Nancy, I think. She will be covering some of the other questions that you have been asking around when are you going to introduce SCG in countries and how you're going to do it.
Thank you, Mercedes. Thank you to all the panelists and the moderators for this wonderful session and for addressing the questions that we had. I would like to address these questions that we have on how to introduce this to countries. The Labor Care Guide and the user manual have already been published and launched, and this means that it is available for use by any country globally. Like we have all heard, this Labor Care Guide replaces the old partograph for labor monitoring because it includes all the recommendations that were made in the 2018 intrapartum care recommendation for a positive childbirth experience. So to answer some of the questions that you have raised, if a country is interested in introducing the Labor Care Guide, which is actually a WHO recommendation that we move to this tool. Since this is a new tool and we do not have in-country capacity for almost all the countries in the region, we would expect the country to request for support to do this. There is a system where this happens, where the Ministry of Health requests through the WHO representative office for technical support to help the country first to customize the Labor Care Guide and then to train a core team that can be able to cascade the training, and then the other partners, we always work together with UNICEF and UNFPA to support the implementation and rollout of this team. We strongly discourage the the notion that everybody in every facility takes the labor care guide and starts implementing it on their own without a national guidance that will help us to standardize the rollout and the use of this guide in the country. And so we have on this call a staff from WHO, UNICEF, and UNFPA in the different countries that you can engage with, and we will be able to assist you to organize for the in-country training. What we have done in this series is to introduce the tool to you so that you have a rough idea of what the tool is and what it entails. But when we come to the country, we will actually do a complete training, which if you ask the panelists, I think it took 2 to 3 days to have a really complete training of how to use this tool with practical experience in class and in the labor ward on how to use this tool. Like we said, the UN, we work through government and we respond to requests from government. So we will not come to a country and start a project on the LCG guide because that was already done in the pilot, but for implementation, it is country-led by the Ministries of Health. For those of you who are program managers for maternal health in the different Ministries of Health, this is the time to engage your WHO, UNFPA, and UNICEF counterpart in your country on discussions on how we can now come to the country and support you in this process. There were questions about doctors and other care workers. Like you heard, this tool is supposed to be used by any healthcare worker who provides maternity services. And that means nurses, midwives, doctors, clinical officers, and other health workers that are directly providing labor monitoring for pregnant women. Initially, we had felt that there is a different approach that we are going to use in the introduction of this tool with the obstetrician gynecologist. And that is why this first webinar was focusing on the nurses and midwives, because they are more central in the actual day-to-day monitoring of the pregnant woman in the labor ward. But we would like to say that we are going to engage with the obstetrical and gynecological societies in the region. That includes ESARO, it includes AFRO, it includes SAGO, WAHO, and so on. And we will be having specific targeted webinars that will encompass this group of healthcare workers. But all in all, we believe that for this to be successfully taken up by countries, it involves a team approach, and we are looking forward to midwives, nurses, and doctors working together to improve monitoring around the time of birth. We also have this whole series as E and M learning on the WCEA platform. So for those of you who are linked to the platform and who have the app, you will be able to access this full presentation as an E and M learning course that you can be able to use. So let us say that we as WHO, UNICEF, and UNFPA, we are ready to provide the technical support and to facilitate that so that we can have the labor care guide introduced to all the countries, specifically in the Africa region. But this tool is not for Africa only. This webinar was organized for AFRO, but the tool is a global tool. You have heard it's being used in Australia, UK, and other countries for improving the monitoring of labor and towards better birth outcomes. So that is what I can say in terms of introducing the tool to the countries. So we have had quite a good session, and I would just like to thank all of you for coming to this webinar. But to give us some closing remarks, I would like to call on representatives of the 3 agencies to give us some closing remarks. First, I would like to welcome Fatima Gohar, maternal newborn child specialist for UNICEF ESARO, to give some few remarks. Over to you, Fatima.
Thank you so much. I'm part of the team, so it really sounds a bit weird closing remarks from my side, because Nancy has said it all. But I would just would like to, from bottom of my heart, convey our sincere gratitude to all our great facilitators who have been with us throughout this month of March, and for all these magnificent 3 webinars, which has really, it has really mobilized us. The information, the enriching information which we have received from our colleagues, Mercedes, Veronica, Rose, beginning, all of you, and then sorry if I meant anyone, and then our panel was, I think you have closed that circle of all the missing information, all the queries which we had. Of course, it would not replace the training itself. That's another piece we need to work on, but this was in itself was really, really enlightening for all of us. So thank you so much to all our great facilitators, esteemed speakers today from around the world and from our region. And then to all the participants, you have been with us throughout this month, 3 comprehensive sessions, and thank you so much to you and WCA platform. Thank you so much for organizing it for us. And on behalf of UNICEF, I would say we are here as a team with my colleagues, Nancy and Mona. We will be with you throughout this journey, so don't think that we just did this webinar and we'll forget about it. No, we'll continue working with you, and as whatever Nancy said, we will be together on this journey. Lastly, I would just say that let's invest more on systems, even if we are working at provider level, as a midwife, as a nurse, as a doctor. See how can we strengthen our system even at our health facility level. And let us work together as a team, as a multidisciplinary team of great professionals. And I wish you all good health, safety, and well-being, and we'll be in contact, in touch. I'll stop here.
Thank you, Fatima. Thank you for those wonderful remarks and for all that you have done in the organizing of this webinar series. I would now like to invite Richard Delat, who is the program specialist for sorry, there's an echo. Over to you, Richard.
Thank you very much, Nancy, and thank you very much to everyone. And first of all, I have to really acknowledge the tremendous work of Fatima and Nancy and Muna. Fatima, obviously from UNICEF, Nancy Kidula from WHO, and Muna Abdullah from UNFPA, for really driving this initiative and being pioneers in the use of this platform. I think what we're seeing is a very powerful expression of UN reform in action. And this is one of the things that we at the Together for ESARO program are trying to promote. But it also shows how when the UN combines its technical resources, we can make a significant difference, not just to those working on the front lines, but also to those in our communities and in need of care and support. I also would like to acknowledge all the presenters who have contributed and have made this possible. And also just to say thank you to the World Continuing Education Alliance for the platform, as well as to acknowledge our funder, Sweden, without whose funding this would not have been possible. It's quite amazing to think that there were 555 people on this call and who have participated in various sessions. And I think this really speaks to the power of electronic medium and being able to efficiently and effectively disseminate global guidance to countries. But I think, as mentioned by other speakers and presenters today, this does not replace the need for in-country adaptation, adoption, and training. And I think, you know, as other speakers have said, the UN agencies are in all the countries, do make use of the resources to call on this regional team to also come and make sure that we bring this down and cascade this down to the country level. Just to say that this will be the first of many such engagements using this platform, and we definitely look forward to taking the lessons learned and using this to help improve. Some of the comments that we've heard back from participants is especially around the translation into French, and we're currently looking into this. But if there are other constructive inputs that participants would like to make, I think we're surely open to hearing from you and to improving on the experience in using this platform. Finally, just to say thank you to you, the participants, and especially for staying the course. I mean, this was a 6-week program, and I think, you know, we really look forward to working with you in taking this forward and making this a reality at the country level. Thank you very much, and back to you, Nancy.
Thank you, Richard. And just to let everyone know that Richard is actually coordinating the Together for SRH joint UN program that has provided the funding resources to make this possible. Finally, I would like to call on Mercedes to give some remarks on behalf of WHO.
Thanks, Nancy. And we are from WHO very pleased to see that so many midwives from Africa, but I think also from other parts of the world join this webinar series. I think that combined with your clinical practice, it might not be easy to do it across the month, but I think that it shows your commitment with your work and also with the women and babies that you are caring for. At WHO, we really believe that this new tool, the Labor Care Guide, will help you to provide high quality midwifery care. And it's about ensuring a positive experience during labor and childbirth for those women and their babies, as well as providing good clinical care. And you know better than anybody else that that will make a huge difference for women, for babies, and for their families. That providing that care that is respectful, that protects their dignity, that includes the emotional support that they will need as they go through labor, and that allows you to use your good communication skills and your clinical knowledge will be a game changer. And we are really happy to be supporting that from WHO. So today we hear real life experiences about using the SCG. We know that at the beginning it might sound difficult, and moving away from the partograph we are familiar with will provoke some anxiety, and that you still have lots of questions. I must say change is never easy, but I'm very confident that, and you know better now, what motivated WHO to review and revise the previous partograph and to develop the SCG. And as some of the midwives that participated in the development of the SCG shared today, as you start using this tool, you will realize that is helpful, and that will help you, as I said before, provide that high quality care that all women and babies deserve. So now that you know what the labor care guide is, we at WHO, we see you as the main advocates and future users of this guide. We would like to see as much countries as possible and facilities starting to use the tool very, very soon. And for this, we also count on you, because from your countries, you can also help us pushing for implementation as soon as possible. So I really hope that we will see you again soon as your countries implement the SCG and as you start using the SCG in your practice. I wanted to thank, of course, my colleagues in the African region from the WHO, UNICEF, UNFPA, and of course, WCEI that provided the platform that made all these webinars possible. But I think that the bigger thanks goes to you, all the participants, for your commitment with women and babies and for all your hard work, especially, I must say, during this current pandemic and the difficult situations that some of your countries are going through. So please keep safe and keep advocating for the health of women and babies in your countries. Thank you a lot.
Thank you, Mercedes. Thank you, everyone. We really are grateful that you are able to be with us. As everyone has said, we want to give a special thanks to Mercedes, who has taken time off a very, very busy schedule because she's also anchoring the work on the postnatal care recommendation to personally facilitate and organize these sessions for us. We would like, on behalf of the organizing team, to also give a big thank you to our panelists, Veronica, Caroline, Tina, Violet, Prisca, Angela, and Rose. They have been wonderful in sharing their experiences and in explaining to us all the nitty-gritty details of the new labor care guide. We want to thank WCEA. They have been excellent in providing all the ICT and logistics recommendations. Some thumbs up for you and Craig. And we want to thank Together for SRH for making this possible through the project. Thank you, everyone, and we look forward to working with you in making this tool widely available in your country and being used in your labor wards until no woman dies from preventable maternal causes. Thank you and goodbye until next time.